Last but not least, I don't even need notes for this one. Dr. Eileen Reynolds, my friend since we were first-year medical students together, my amazing hero, and our SGIM president.
I want to start by congratulating the speakers so far this morning. The abstracts were incredibly invigorating and great examples of what we as general internists care about and think about and feel about, and I want to thank you all for presenting those this morning. And my congratulations to Joanna and to Bob, amazing beacons in our society, and the work that you've done and the way that you've led us all behind you. I really want to congratulate you on your awards. I, in particular, have to call out Sam Edwards for being a plenary presenter 2 years in a row, and I relate it all to the place he did his residency. Fantastic group. When I was a resident, Steve Cummings told me that the hardest talk to give, the time you would be the most nervous, was when you were talking to the people who were most important to you. And I have to say that until today, I did not believe him. And it is true, I'm quite nervous and humbled to be here speaking to all of you. And I've been thinking about this for a while, trying to figure out what important thing I could say that would be meaningful on this 40th anniversary of the first meeting of the society that was later named SGIM. I am going to reflect a little bit on our society at 40, on what's resilient about it, what's gritty about it, and make a couple of suggestions for how to move forward in the future. To do this, I read many of the president columns in the Forum newsletter that you all get. We actually don't have records all the way back. The Society has them back to 1985, when it was actually the SGIM newsletter. And so you'll see from time to time, I'll be quoting some of the columns that I've read as I reflect on our resilience as an organization. But first, I'm going to start in 1993, when I'm a senior resident in primary care at UCSF. It's a brief year punctuated by very long nights. I work 100 or more hours many weeks, but I'm protected by my 1 day off a month. It's really dating myself. About a third of my inpatients are dying of AIDS. It's exhausting, compelling, and rewarding work. My continuity practice is a refuge with complex medical patients, like the 20-year-old liver transplant nurse specialist who herself had a liver transplant, like the 22-year-old who had survived osteogenic sarcoma as a child to bike across Europe with her one leg, but who returned with an ejection fraction of 10%. And like my 80-year-old Iranian immigrant patient who didn't speak English, who had breast cancer, smoked like crazy, had multiple PEs, and made me the same Christmas gifts every year that she made her daughters. I care for my patients longitudinally through inpatient and outpatient rotations. I take a full-time faculty job in the Division of General Medicine, seeing new patients and follow-up patients almost every second of every day, like any new clinician, educator, faculty member. I see more patients in a session than I thought was possible. I stay late each night, a strange luxury because my husband is a surgical resident and he stays later. One day, as I'm standing by the wall of windows at the front of the clinic, one of the assistants comes up and taps me on the shoulder. She asks me if I would be willing to see a patient who had walked into the clinic who needed something. I'm not sure what. I have a full schedule. I know I'll stay late, but I say, yes, of course. And I mean it. And I am surprised that I mean it. I am surprised that it feels okay to me to take on one more thing, to see one more patient, to stay a little bit later, because it's the first time I have felt that way in 3 years. And that wasn't a feeling of burnout, it was a feeling of resilience. And it was the first time I realized that I probably had been burned out and had acted accordingly previous to that. At this meeting, we will be discussing burnout, resilience, grit, and engagement. This theme has resonated with our members, but also across the medical community over the past several years, as we have seen the ACP, AIM, the AAMC, the National Academy of Medicine, amongst others, start projects or committees or task forces that aim to work on the physician burnout problem. At this meeting, you will hear about recent and emerging evidence that burnout is related to lower quality of care, lower patient satisfaction, higher physician utilization, and many other things. We will talk about personal dimensions of resilience, that is, what we as individuals need to do for ourselves to protect ourselves. Sleep, eat, exercise, grow support networks, things that may even help us recognize our own frailty and when we need help. But we will also hear about institutional and organizational drivers of burnout, as well as many systematic interventions that can prevent burnout and enhance physician engagement. We are fortunate in our society that Mark Linzer has been doing this work for many years. Just on Tuesday, he led an all-day session called WELL, sponsored by ACLGIM, that aims to create wellness championships in divisions and departments around the country. Colin West at the Mayo Clinic, also our member, has worked together with his colleague Tate Schoenefeld to elucidate drivers of and interventions to prevent burnout. In this graphic from their recent review article, the middle box shows known drivers of burnout, but also drivers of engagement. Mark Linzer's work has also focused on interventions that enhance control, work-life integration, and values alignment. Drivers of burnout and engagement can happen in many categories, and in this pictorial from the same review article that I recommend to you all, we see many categories, including individual factors, work unit factors, organizational factors, and national factors. There are many ways that we can intervene to try to improve engagement and prevent burnout. In fact, we know from this recent systematic review that interventions directed at organizational or systematic corrections instead of at individual physicians are actually more successful at preventing burnout. Individual interventions like mindfulness do help, and shown on the bottom graph, you will see that there is in fact a statistical overall improvement in burnout from individual directed interventions, but there is a more substantial burnout from the organizational directed interventions in the top graph. Again, while it's important that we as physicians intervene upon and care for ourselves, it's more important that organizations and systems focus on systematic improvements to keep physicians engaged. The first National Physician Burnout Survey was done in 2011. Residents and students in the audience, it's important for you to know that while that first national survey was done by Tate Schoenefeld, his initial work on this subject started in 2002 when he was a resident at the University of Washington and needed something to do with his research month. He studied burnout in the residents in his own program, and that has led to a career that has exploded since that national survey in 2011. There has been a crescendo of attention paid to this topic over the last 5 years, and I thought when I chose this meeting theme that we were kind of on the cutting edge, a crescendo, riding the wave, and in fact I could have said this: even in the most rewarding of careers, there is always the potential for burnout. the great demands of multidimensional role models of SGIM, the great demands of multidimensional professional roles of SGIM members place us at special risk for burnout. It is vital that we understand how we can protect ourselves from this phenomenon. I pledge to work with the program director for the annual meeting to encourage workshops and other presentations regarding career development and burnout. I could have said that, but I didn't. Lee Goldman wrote it in the forum in 1990. The program director that year was Wishwa Kapoor, and many of our presidents have written about burnout and work-life balance in the forum. I may have missed some of you. My apologies if I missed your column on this, but Lee Goldman, Bill Tierney, Nikki Lurie, Sankey Williams, Kurt Kranke twice, Martin Shapiro, Bob Centaur, and Nattinger, Eric Bass, Bill Moran, and I wrote a column on burnout earlier this year. We actually have, as a society, been remarkably reflective about this, and I think it says a lot of good for us that we care about the lives and balance and engagement of our members in our many varied jobs. But now I would like to turn to the main part of my talk today, which is actually about organizational resilience. And I'd like to tell another story. We're fast forwarding to 2002. I have been a faculty member at Beth Israel Deaconess Medical Center for just over a year. BIDMC is in the Boston newspaper regularly with stories of leadership turnover, financial distress, general dysfunction. Our new CEO arrives. He's not a physician. His greatest claim to fame is that he was the head of the Massachusetts Sewer Authority for a number of years and takes personal credit for the Boston Harbor cleanup. I'm not going to make any parallels between BIDMC and the Boston Sewer Authority. After living through the Hunter Group in my time as a faculty member at UCSF and at the University of Pennsylvania, I am skeptical. But he is a strong leader. He promotes transparency, and he's able to channel the remarkable passion for patient care and for BIDMC itself in the physicians and staff. Instead of slashing budgets and laying off staff, he holds a series of town hall meetings to ask the staff what to do. And then he does it. He focuses the goals around quality of care, engaging doctors and staff together, and solving the problems at hand. He's able to fully utilize the resilience of the people and of the institution to create a rapid turnaround. Today, BIDMC is the fastest growing health system in New England. We are financially vibrant and healthy. Paul Levy is no longer the CEO, but that's a story for another day. But really, what is it about an institution and an organization that features resilience? What creates institutional resilience, and how can we capture it for SGIM? There's not a lot written about organizational resilience. This is a topic area in the business literature that mostly has to do with helping businesses or communities survive crises like Hurricane Katrina. But this pictorial is drawn from a New Zealand consulting firm that helps businesses be resilient. And it says that the resilience they seek is the ability to survive a crisis. We're not in a crisis for SGIM, but to thrive in a world of uncertainty. And I think we are in a world of uncertainty right now. I've been reflecting on resilience and grit in this construct, and I want to talk with you a little bit about some of the domains and how they may relate to our organization here at SGIM. First, leadership. Paul Levy was an extraordinary leader at just the right time for BIDMC. He helped us at BIDMC capture our resilience. SGIM is in no way in turnaround or crisis mode, just to be clear, but we have had a failed attempt this year at finding a new executive director, and leadership is very important. Council had a hard year this year, but came through with a decision to move to a part-time physician executive leader for SGIM, and I am incredibly excited to see what this can bring to our society in terms of our ability to thrive in a world of uncertainty. Tom Gallagher is leading the search process. We have a really fantastic list of candidates for that position and look forward to being able to announce a selection to you, hopefully by the end of June. Next, I would like to turn from leadership to unity of purpose and innovation and creativity. We are generalists. It's hard to imagine a unity of purpose for our organization. We love to support the many, many, many varied projects and interests and passions of our members. What we may lack in unity of purpose, we make up for in innovation and creativity. This organizational chart could be today. It's close to today, but actually it was published in the SGIM Forum by Bob Fletcher in 1991. If you look a little bit more closely, you'll see that there are some interesting titles to some of the interest groups, committees, and task forces. So there was a task force on microcomputers. And I won't go on. There are some interesting titles. But we were a large organization already 25 years ago. We had spread our wings. We had many, many groups working on many, many passions. Where are we today? We have 20 committees, many of which have subcommittees. We have 8 task forces, many of which are the same as they were in 1991. We had, interestingly, we had 10 regions in 1991. Today we have 7. So I guess that's somehow getting us more unified. We had liaisons with many external organizations then, and we're proud. I counted about 38 in putting this talk together. And what's been really amazing is that it's no longer just that we kind of have some sort of a connection with those organizations, but as SGIM has matured, so too have our members, and our members are often leading or in leadership positions in many of these external organizations, or at least they were until January, some of them. Interest groups, there were 20 interest groups, and now there are 91. So not a lot of unity, but a lot of creativity and passion. In all seriousness, though, not having a unity and purpose puts us at some risk of splintering our focus, splintering our assets, and splintering our support. Last night, led by Tom Gallagher, the Council and committees and task forces discussed how we can engage our members fully, but also how we can limit the burnout experienced by our staff who work so hard to support these many endeavors. Begun initially by Marshall Chin, SGIM has 6 strategic priorities, and we're working to focus our resources on those areas of most important strategic need to our organization's health. And if we are able to do so, I do believe it will help both our staff resilience and our organization's resilience. SGIM was created as an organization that advocates for generalists. So another way to interpret unity of purpose may be to combine it with situational awareness. And I want to speak for a couple of minutes about advocacy. We have advocated in a unified way since the founding of the Society in 1978. We have advocated for patients and access to care, for funding for education, for funding for research, and for enhanced payment for the clinical care provided by generalists. This has really been a consistent and unified message. Through the years, we have been consistent in our message, consistent in our desire, and I think it's clear that in the uncertain world of today, there is an ongoing need for our strong advocacy for all of these advocacy positions. This year, situational awareness meant strengthening our commitment to advocacy by enhancing the work of our Health Policy Committee, by expanding the scope of our work with CRD, our Washington, D.C. based consultants, But again, this is not new this year. It has long been a focus of our society. Nearly every president in SGIM's history has written a column about the need for advocacy in one or many of these places. Here is just one example talking about SGIM's role in whatever the new health system should be. It must eliminate the incentive to provide too much care or too little, and the incentive to care for some patients but not others. It must find a mechanism for financing care that will assure that the services to be provided to all are sufficient. To this end, the decision-making about this should not be left to politicians who want to minimize taxes, to doctors who want to optimize incomes, or to private companies that want to maximize profits. It must be made by a group that can remain immune to these parochial goals and get above the fray. I believe that group was intended to mean SGIM, and Martin Shapiro wrote that in 2003. It echoes hauntingly our situation today. Effective partnerships are the lifeblood of expanding our reach. Not only does SGIM have active engagements with 38 by my count, but probably more external organizations, including many branches of the government, our organization has matured into, as I mentioned, our members leading those organizations. In addition, over the past couple of years, we have been meeting very actively with groups from family medicine and pediatrics. We clearly need to engage like-minded organizations in advocating together in our environment of uncertainty and to enhance our ability to advocate for generalism. This ongoing collaboration with family medicine and with pediatrics has resulted in a population health conference that Marshall Chin attended last year, a measurement conference that a handful of our members will be attending in the fall, and hopefully an ongoing primary care collaborative that can work to advance many of those principles. But this is not the first time that we have been working with family medicine or with pediatrics. In fact, leaders of SGIM have been meeting with leaders of family medicine and pediatrics for years, written by Bob Fletcher, the forum in 1991. It is important that we continue that work. It's been now ongoing for decades to try to align ourselves with like-minded generalists. In addition, throughout its history, the leaders of SGIM have had to make difficult choices about how and how much to spend of our scarce resources on political advocacy. If we are to have at least some effect on these large issues, SGIM must form alliances with other organizations that share our sentiments. Steve Finn wrote that in 1998. I want to move on now to talk about internal resources. And by internal resources, I'm going to talk about membership, because our members are our biggest internal organization resource. But first, I need to talk a little bit about a few secular trends between 1978, when that first meeting had 178 attendees, and today. So the population of the United States has grown quite substantially in those 40 years, from just over 200 million now to just over 300 million. Life expectancy has increased dramatically from about 73 in 1978 now to almost 80 today. So there are more people, and those people are older. In addition, the uninsured rate, happily, has dropped substantially, both the number of uninsured and the percent uninsured. However, while our meeting attendance has grown, especially in the past couple of years, our membership has actually been relatively flat since 2000. If you imagine a new young society with 178 members in the first year, there was dramatic growth in membership over the first 20 years that SGIM was around, but the membership numbers have been relatively stable since about the year 2000. One more thing has happened over those 40 years. And that's been a dramatic increase in the number of hospitalists from zero called hospitalists in 1980 to more than 50,000 today. I think that for SGIM to maximize the internal resource of membership, we need to start thinking broadly about what our umbrella is. We need to start thinking broadly about what generalism is. And we need to think about how to capture the academic hospitalists. About 600 of them are members of our organization, but there are many more who could benefit from our philosophical approach to general medicine, which is independent, I think, of the place you see the patient. It is a philosophy about how we care for patients and the approach to caring for patients. It's not necessarily about whether it's in an office building, in a home visit, or in the hospital. And we need to bring those hospitalists fully into our society. Part of what we do here is that many of us are primary care doctors, and we say the word primary care when we mean to say general medicine. And as you go through the rest of this meeting, I want to ask for you to be conscious of saying the word general medicine if you mean both hospital medicine and primary care, because we are philosophically aligned. In addition, we should reach out and broadly engage the osteopaths, most of whom are generalists. And now their accreditation will be running through the ACGME in a single unified accreditation organization. There is much that we have to learn from them and they from us, and I would hope that we would see them as generalists under our big umbrella. And we have not had many family physicians in this organization over the years, but increasingly I think we are working with family physicians, at least at home. They have much to teach us, and we have much to learn from them. And so I think we need to consider how to engage family physicians in the work that we're doing as generalists. We are working actively to increase membership by working on the attractiveness of general internal medicine as a career. If you are a medical student or a resident, raise your hand. Medical students and residents. Woo! The number of residency slots has increased nationally over the years that SGIM has been an organization. These are different scales, and so internal medicine has gone from about 5,000 to about 7,000 slots. The total residency slots going from about 15 or 16,000 up to about 26 or 27,000. Part of that is related to a different way of counting slots over the past couple of years, but there has been a dramatic national increase in the total number of slots. We have not seen an increase in the number of primary care slots. There were about 200 primary care slots in 1980, and there are about 250, 300 primary care slots in the match today. There was a high in the middle there of about 600 slots, but in reality, we are not training lots of residents in primary care programs. The attractiveness of primary care internal medicine is on everyone's minds. Ironically, at a time when SGIM is stronger than ever, fewer students are entering careers in our field. The attractiveness of primary care internal medicine is so close to the mission of SGIM that we need to develop specific plans for what we should do that is not already attended to by other organizations. Written by Bob Fletcher in 1991. So the end of the world was coming then, and it hasn't come, but we continue working on ways to replenish general internists. It goes back to that hospital medicine graph and thinking about ourselves as generalists in philosophy. We are doing many great things with our Proud to be GIM campaign. Check out the YouTube channel with multiple videos. Some of the students and residents are here on scholarships. Some of you attended Proud to be GIM events at your institutions over the winter. And we hope that many of you will become long-term members of our society. We also need to work on the things that prevent people from being fully engaged in wanting generalist careers. Although the benefits of primary care are widely heralded, There are also glaring deficiencies in our systems of primary care that most of us would readily acknowledge. Allocated time for visits are too short, access to ancillary services is difficult and fragmented, information systems are cumbersome, and documentation requirements are onerous. Oh. Steve Finn, 1998. So we continue to work to improve all of those things. I'm not sure that any of those problems has gone away, but there is more to be done, and our society continues to work to try to improve the practice environment. And finally, I want to talk about leveraging knowledge, which I'm going to call education. Generalist physicians lead some of the largest and most outstanding categorical residency programs in the country. Many of you are in the audience today. SGIM members have led the revisions of the program requirements that stand today as the rules of the road for our residency programs. Yet we continue to work in an environment that prioritizes inpatient care and training above outpatient care, or home visits that we heard about in two different sessions today. We place our residents into practices where physicians are burned out and where many of us are trying to buy our time out of patient care to do other pursuits. Residents love the 4+4 model or 2+2 model of inpatient and outpatient dichotomized training. It protects the inpatient training and protects the inpatients from the residents having to go back to clinic longitudinally. But it creates enormous discontinuity in the outpatient setting. It creates enormous discontinuity for the residents in caring for their patients. It creates enormous discontinuity for the practices. And most of all, it's pretty unfair to the patients. More generalists come from categorical programs than from primary care programs, but we are not giving the average categorical resident the skills and practice to feel either confident or competent in ambulatory general medicine, nor the fundamental understanding of how much complex care can truly happen in the outpatient setting, which will help inpatient generalists do their work and return patients to the complex care in the outpatient environment. These two last quotes: ultimately, the validity of general internal medicine rests with its central position in the care of the patient. And if internal medicine is to accept fully its generalist core, it must ensure that all its residency programs, not just the primary care tracks, can produce competent generalists. Steve Schroeder, Shrepsum Newsletter, 1985. I got Shrepsum in there somewhere. It's like a requirement, unwritten rule. We will continue in SGIM to work on the national drivers of burnout, and we will continue to help you learn about individual factors, work unit factors, and organizational factors. We will ask for your help on our national approach with a new fundraising campaign this year to turn up the volume on our voice so that we have enhanced ability to advocate for our patients and for their care in a way that will help our education and advocacy efforts. You can donate online, you can donate at the registration desk, you can donate through the app in some way, and we will be asking you to donate. I have downloaded the app. I'm more competent electronically than that sounded. I want to end by saying that I actually believe that SGIM has resilience and grit, that we have shown resilience and grit over the many years of our existence, and that I look forward to the future with new leadership, enhanced membership, commitment to education, advocacy, research, funding, and new members and new trainees with great anticipation. But I want to then go back to personal resilience just for a moment. I have had an incredible blessing with mentors and advisors and colleagues, friends at UCSF, at the University of Pennsylvania, and now at BIDMC, who have helped me understand what it means to be resilient and what it means to be a generalist. I can't name them all. If you're here, you know that you're among them, but it's been a blessing to have a home in this society and to have been shown that this society was home by my mentors in all three of those places. My residents help bring resilience, I think, for all of us, teaching new learners to see the joy and the commitment to our patients that they bring, the innovation that they bring, and the future that they will bring to this society helps with resilience. This is my division of general medicine at BIDMC. I am incredibly lucky to work in a resilient organization with amazing colleagues and peer mentors and a great faculty. It's added to my resilience this year to have the amazing staff of the national office who has had their own issues with turnover, and you heard a little bit about leadership today. They're all special, they're all fantastic. Thank them when you see them around the meeting. In particular, Lisa Lee has taken over after Sarah Jane Garton's retirement in the middle of the year. Lisa is personally responsible, with help from Julie Michalski, for the app and for many of the enhancements in the meeting this year. She has really done a fantastic job. And Kay Ovington has been our fearless leader, called by different names and different titles over the course of the year, and she's really a remarkably resilient human being to which our organization owes an immense amount. So thank you, Kay. Council this year has been phenomenal, really an amazing group, an eclectic group of people with many different opinions and ideas and a great ability to discuss them all. And I, in particular, want to thank these two ladies on the podium with me. I don't. Dawn and I were classmates in medical school, as you heard, and she has not changed one bit. And Margaret has been a fearless leader of the meeting now for 2 years, and they have done really a fantastic job, so I want to publicly thank them. I'm leaving you on Saturday afternoon in the hands of Tom Gallagher, and I do want to explain that in our medical school yearbook, you got to choose your own pictures. And I cannot explain, but maybe Tom will explain to you why he chose the one at the top and the one on the right, and who that goat-like animal is. Is that a goat? It is a goat. But it is a beautiful picture of his wife, Susan. Tom is going to do a phenomenal job over the next year of helping get us to organizational resilience. And then finally, for me, the most important part of my resilient life comes not from yoga, not from mindfulness, not from many of the strategies that you all use to provide your own brand of resilience and burnout prevention. Mine comes from my family, from my parents in particular, both public school teachers who ingrained in me from the beginning a need for teaching and learning. My father retired to be our nanny when we moved to Boston. That is a phenomenal model and an incredible, I recommend it, and an incredible amount of support to a young family. My kids are the best place to understand what's important in life. These are them at the beginning of my counsel journey on SGIM, growing a little bit more. And Dan is here. My husband is actually my best friend, an incredible partner, my biggest fan. And one of the nicest things I could say about him is that he would really make a phenomenal general internist. I'm going to end there, and I want to thank you for the privilege of having served in a really crazy and tumultuous year as president of this amazing organization. Thank you so much.